You're listening to Case by Case, the podcast where medicine meets real-world practice, one clinical case at a time. Brought to you by a continuing education company, this series brings you front-row access to compelling case studies recorded live at top-tier CME conferences across the country. Each episode, we dive into a single, real-life medical case presented and discussed by leading experts in the field. It's medical education, elevated, engaging, and deeply relevant to today's practice. This is Case by Case. Let's begin.
Okay, case 3. We have a 60-year-old male with a recent stroke. He also has hyperlipidemia, BPH, and reflux. He's taking metoprolol 200 once a day, doxazosin 8 milligrams once a day, trendelapryl, verapamil. He's on a combo for 240 once a day. He had been on other medications. He had erectile dysfunction and hypokalemia with thiazides. He had edema with amlodipine. And he's also taking atorvastatin 80, aspirin, and omeprazole. His blood pressure is 210 over 125. We repeated after 5 minutes of quiet rest. It was 163 over 104. His BMI is 36. Home readings are also elevated, 140s to 150s over 100s consistently. His wife, who came with him to the appointment, says he snores. What is the next best step in his management? All right, a little bit of everything in here.
That's the patient you're going to see Monday morning, by the way.
Right.
That's right.
So for me, this is somebody that really should be screened for primary aldosteronism. It's not wrong to do almost any of these things, but I think the most important next step in this patient's management is to screen for primary aldosteronism for some of the reasons that were covered earlier today. Dr. Basile went over a lot of these earlier today. I'm not going to go over them in a lot of detail, but like him, to me, primary aldosteronism and sleep apnea are probably the most important two secondary causes that I see, look for, address, and treat. This is in your handouts for reference. Again, this is just a reference for you, but these are screening tests in appropriate patients looking for the specific causes of secondary hypertension. I'm not going to belabor this too much in the interest of time. We saw a different study. This is a VA study that shows how abysmally we do for screening for primary aldosteronism. Previously, it was thought that PA was less than 1% of patients. It is way more common than that. We've covered this as well. Primary aldosteronism is a spectrum. I think we used to think about it like type 1 diabetes. You had it or you didn't. It's much more like type 2 diabetes. And much like type 2 diabetes might develop 1 year over the next, if you screened somebody for primary aldosteronism 2 years ago and they were negative, that does not mean that they don't have it today. And so you need to think about it and screen for it, and then you need to rescreen if the clinical circumstances change to make sure that you're not missing patients who have primary aldosteronism. Hypokalemia is sufficient, but definitely not necessary. There is the reason why we care about primary aldosteronism, and again, covered beautifully by Dr. Tuttle. Aldosterone is a toxin. It is a poison to our organs. And so you have increased risk of all of these downstream effects, and less than 2% of eligible patients are screened. So who should we screen? And again, new guidelines both from the Endocrine Society and in terms of blood pressure, but severe hypertension and resistant hypertension, and then hypertension in addition to any of these other categories, which when you look at this list is a lot of the patients that you're seeing. And there are some advocates that we should be screening all stage 2 hypertensives for primary aldosteronism. So more than we are, which is 2%. How should we evaluate aldosterone and renin? It is no longer recommended to hold most antihypertensives prior to the initial screening. Exceptions could be MRAs and amiloride, though if a patient has a positive screening test for PA on a low dose of spironolactone, they are really positive. So you still should be screening if you have a very high clinical suspicion. You can obtain screening tests at any time of the day. And for equivocal cases, if you get results that you're confused about, then you can walk it back and say, maybe we should titrate off some of these medications that might be impacting these results and see where we go. I recommend befriending an endocrinologist and, screening for this and then checking in with them if you're confused about the results. It's complicated, but you will quickly learn to recognize the truly negative and the truly positive, and then you can go to them to discuss the gray cases that are in the middle. So our patient had a sodium of 143, a potassium of 3.6, and a bicarb of 26. His renin was nearly undetectable. Aldosterone was 20, and he had a ratio of over 300. We keep a list of our record aldosterone renin ratios. This was up there. I had one in the 600s, but this was one of the higher ratios that I've seen. TSH of 2.4. I did get a UACR. Calcium of 9.8. And he had imaging, an adrenal protocol CT scan with a 7-millimeter left adrenal nodule consistent with an adenoma. So what is the next step in his management now? Okay, we have 39% referring to endocrine surgery now. We have 20% checking plasma metanephrines and a DEX suppression test. 22% are going to start MRAs, depending on where you are, not wrong. Saline suppression test, adrenal vein sampling. So in patients who have adrenal incidentalomas, which I have a hard time calling this an incidentalloma because I was looking for it. But in patients who have adrenal nodules, we are obliged to rule out other secretory, biochemically active hormones. And you can have co-secretion. And so even though we know that he has aldosterone, you can also have co-secretion. And so we do want to make sure that this patient isn't having other biochemical activity from that adrenal nodule, even though it is small. You want to raising your hand?
Yeah, go back one slide. I would add one option to that for most primary care clinicians to refer to an endocrinologist or a hypertension specialist for them to do the rest of this workup.
Absolutely, 100%. If you're just confused about what to do there, endocrinology or a hypertension specialist, somebody who has some experience with this. Good point. Again, adrenal nodules are quite common. The vast majority of these are going to be non-functioning, but in patients who also have hypertension, we need to evaluate for hormonal functioning, including cortisol, aldosterone, and PHIAs. Okay. Comments on that?
Can you go back to the first slide?
Oh.
I mean, on the case.
Can we talk about it without going?
No, I got to make a point. I got to make a point. Got to make a point.
You can make the point without...
I can't. They need to see it. I don't know if they have it in their book. But I'd like to see it.
Oh, good Lord. Here? Are we here?
Yeah, that's good.
Okay.
No, those, yeah, okay. Hypertension meds, okay. So, I mean, he's already failed. He had side effects from HCTZ, right? And
Thiazides, yeah.
Okay. So, why would you add metoprolol? It is not a good drug for, beta blockers are not good for stroke. This guy's had a stroke. It is not a recommended drug unless there's truly a compelling indication. It has bad performance for outcomes, especially with stroke. It's not recommended as one of the first three. Why wouldn't you think of spironolactone sooner? I mean, it's been on your shelf. You have it available. My first question would be, will the patient consider surgery? That, to me, is very important. And then, if the patient would consider surgery, then I'd consider a CT. But he's snoring. He's got plasma aldo elevation. And you did the test. So I want you to start thinking about spironolactone or drugs like that sooner than later and use them. So that's my point. I just, I'm in cardiology. I'm not a cardiologist. I'm a primary care clinician. I call myself a primary care specialist. Mm-hmm. I like that. You should do it too. And Dan, I know you feel that way. And I just don't know why the cardiologists in my division just love beta blockers. They think everyone has subclinical atherosclerotic cardiovascular disease. And it's just silly. It's just silly. And I don't know, what was his weight? Did we say his weight? But a BMI is 36. A beta blocker allows weight to increase. So why would you use a beta blocker in someone that's suffering from obesity? Doesn't make sense. Sorry.
Here.
So I want to underline what he said about spironolactone. So this patient in my clinic likely would have gotten spironolactone and not the workup for permeate aldo. I would have, if he had a good response, I may have imaged him to be sure he didn't have a malignant lesion instead of a benign lesion. But I would have been happy in this patient, because I'm probably not sending this patient to surgery. I would have been happy to do a test trial of spironolactone without knowing the diagnosis for sure.
With a lot of respect, I'm going to push back a teeny bit, that before your fingers write the prescription for spironolactone, check the plasma aldo and renin. I think it is so important to give someone a diagnosis, and then you've got a titration goal for your labs, for your spironolactone, and you can tell somebody, I know what's causing your hypertension. I know why you had a stroke. Mm-hmm. You have primary aldosteronism, and we can treat that with targeted medications. And then, I mean, Mississippi may not be as transient as Boston, but I saw this gentleman as a consult. I may never see him again. They may go somewhere else. I want to be able to tell somebody, you have this condition, and it's so important that we titrate. I would start, I love your junk meds. I would titrate the spironolactone and get rid of the junk meds on his list so that we could get him blood pressure controlled, normal potassium, and renin above 1.
And again, I'm going to do the future thinking again. Assuming that's not a malignant lesion and it is an aldosterone-producing adenoma, another approach in the future will be aldosterone synthase inhibition.
Correct.
Which would probably be even more effective because of getting at the mechanism underlying this person's hypertension and target organ injury.
Better tolerated. I mean, the postscript to this particular patient, we'll move on. He's done much better. He's on a lot fewer. He actually had a unilateral adrenalectomy, and I saw him about 2 weeks ago, and he's on 2 antihypertensive therapy with blood pressures in the 120s over 60s. It's just, it's so satisfying when you can do that.
Thanks for watching. If you found this discussion valuable, be sure to like, subscribe, and hit the bell so you never miss a new episode. To explore upcoming CME conferences and earn credits while staying at the forefront of medicine, visit cmemeeting.org. Until next time, keep learning, case by case.